Let's start. Hello everyone. Welcome back to this series of lectures in rheumatology. In continuation with our discussion, we will be speaking about crystal arthropathies today. So let's begin. So what do you mean by crystal arthropathies? So this basically refers to the group of disorders which is characterized by crystal deposition within the joint. Okay, so the characteristic feature of crystal arthropathies is crystal deposition in the joint. So what are the type of crystals which can get deposited in the joint? So the most common or frequently encountered one is your monosodium urate crystals. Okay, so uric acid, monosodium urate crystals is the most frequently encountered one. Then we have CPPD, which is calcium pyrophosphate deposition. Then you can have calcium oxalate deposition disease and calcium hydroxyapatite deposition disease. Okay, so these group of disorders which are associated with crystal deposition in the joints is what we call as crystal arthropathies. Fine. So first let us look at the first and the most common type, which is your monosodium urate crystal deposition, which is also called as your gout. So before we move on and understand what is gout, let us understand uric acid metabolism. Okay, so uric acid is basically a breakdown product which is obtained from which pathway? It is a pathway of purine metabolism. Okay, so we would have seen this in our basic biochemistry classes. Purine metabolism, the byproduct is uric acid. Okay. So uric acid is obtained from two important sources. So we have guanosine monophosphate converted into guanosine, which is converted into guanine, which is converted into xanthine. So xanthine is broken down into uric acid. Also, uric acid can be obtained from adenosine being converted into inosine, hypoxanthine is converted into xanthine, and then uric acid by xanthine oxidase enzyme. Okay, so if there is a problem in any of this, right, so if there is excessive activity of any of these enzymes or the xanthine oxidase activity is more, then uric acid formation can be more. Okay, so basic underlying point that you have to remember is that uric acid is a breakdown product of purine metabolism. So normally the uric acid excretion is around 0.7 grams per day, and when we speak about the urate pool, around 10% is excreted in the urine. Right? So up to 90% will be reabsorbed into the body to maintain the uric acid pool, about 10% is excreted in the urine. So the normal uric acid excretion is 0.7 gram per day. So when there is a increase in the uric acid levels to more than 7 grams per day, then if the excretion exceeds that point, then there is uricosuriia. Okay. So if there is excretion of uric acid to more than 7 grams per day, this is uricosuriia, and this can result in uric acid stones. So whenever we speak about gout, what we have to know is that this is a condition which is associated with hyperuricemia. Hyperuricemia basically refers to elevated levels of uric acid in the blood. Okay. So this is defined as uric acid levels in the blood more than 6 mg per deciliter in females or more than 7 mg per deciliter in males, right? So this is what we call as hyperuricemia. So to understand the pathophysiology of gout, we have to understand what are the causes of hyperuricemia, right? So only when there is hyperuricemia, more uric acid in the blood, will uric acid get deposited in the joints and result in gout. Clear? So let us understand the causes of hyperuricemia. So 90% of the cause, 90% of the times the cause is unknown. Very, very important. The cause is unknown. Most often it is due to genetic conditions or due to underlying metabolic syndrome, right? So what are the risk factors for hyperuricemia in an individual? It can be because of increased age. It can be precipitated by increased alcohol consumption, increased meat consumption, especially your red meat consumption. And the most common associated underlying syndrome is your metabolic syndrome, which is characterized by obesity, diabetes, hypertension, hyperuricemia, right? So the most common cause is unknown. 90% of the cases we do not know the reason for hyperuricemia. It's just present as a part of metabolic syndrome. Okay. Then the rarer causes for your hyperuricemia is enzyme deficiencies. Okay. So what are the enzymes? HGPRTase deficiency. This is associated with Lesch-Nyhan syndrome. Lesch-Nyhan syndrome is characterized by hyperuricemia with gouty arthritis and self-mutilation. Then glucose 6-phosphatase deficiency results in your glycogen storage disorders, which are usually occurring in the infantile period, where you have hepatosplenomegaly, mental retardation, doll-like faces, recurrent episodes of hypoglycemia and hyperuricemia. Okay. Then they can be due to PRPP synthetase, increase in the levels of PRPP synthetase enzyme. Right. So these are some of the rare causes for hyperuricemia. But most commonly, hyperuricemia can be asymptomatic and it can be a part of metabolic syndrome. Also, whenever we speak about hyperuricemia and gout, we should be knowing about the drugs which can cause hyperuricemia, and this includes loop and thiazide diuretics. So very importantly, if a hypertensive patient on treatment presents to you with gout, always go through the medication list because they may be on your loop or thiazide diuretics. Then low dose aspirin, which we put for your post PTCA or post IHT prophylaxis, we give low dose aspirin. Then pyrazinamide, ATT drugs. So patient of pulmonary tuberculosis initiated on ATT complaints of joint pains, always think of pyrazinamide induced hyperuricemia. Then other drugs such as cyclosporine. Okay. So remember these important drugs: diuretics, cyclosporine, low dose aspirin, pyrazinamide. Okay. So this is about the various etiologies for hyperuricemia, right? So let us just revise what all we have learned till now. So hyperuricemia is defined as a condition where the blood uric acid levels are more than 6 mg per deciliter in females, more than 7 mg per deciliter in males. Most common cause is often unknown. It can be part of a metabolic syndrome. Then we have enzyme deficiencies and drugs. Okay. So when do you get this uricosuric? When the uric acid levels excretion is more than 7 grams per day. Okay. And this comes with an increased risk of gouty arthritis, increased risk of uric acid stones. Okay. Fine. Now, what are the presentations of hyperuricemia? So, whenever you have hyperuricemia, there can be patients who have hyperuricemia but they do not have gouty arthritis. So, what we should be aware is that most of the patients have asymptomatic hyperuricemia. So, the most common presentation is the patient goes for a regular checkup and he finds that his uric acid levels in the blood are elevated. So, asymptomatic hyperuricemia is the most common presentation, and asymptomatic hyperuricemia can be a part of metabolic syndrome, and the treatment involves treatment of the underlying comorbidities, treatment of hypertension, control of sugars and bringing down the weight. Okay. So, asymptomatic hyperuricemia you do not treat. Okay. So, no treatment is usually required for an asymptomatic hyperuricemia. This is the first presentation of hyperuricemia. So, this is the first presentation of hyperuricemia. Secondly, you can have something called as uric acid nephropathy. So, uric acid nephropathy usually occurs when there is a sudden elevation in uric acid levels. So, there is a sudden or an acute elevation in uric acid levels. So, where does this happen? This happens when there is high breakdown or high turnover of cells and there is more and more uric acid production. That means that the purine metabolism is increased at a high rate. So, where do you see this? You see it in association with tumor lysis syndrome. You see it in association with tumor lysis syndrome, where there is breakdown of the tumor cells leading to a release in the intracellular contents. Okay. So, this is seen in tumor lysis syndrome, and this presents with acute kidney injury. This presents with acute kidney injury. Third, you have something called as urate nephropathy, where there is a constant uric acid levels are high and it can result in kidney damage and CKD, and this is called as urate nephropathy. And the fourth presentation is urolithiasis, where you can have kidney stones predominantly comprising of uric acid. The fifth presentation is your acute gouty arthritis, where you have uric acid deposition within the joints. Okay, fine. So this is about the various presentations in which hyperuricemia can present. So let us understand what is gouty arthritis. So till now we have understood gouty arthritis basically refers to uric acid deposition within the joints. So this is more common in the middle age. It is more common in the middle age, right? And it is more common in males more than females. When it comes to females, it is usually more common in the post-menopausal age. It's more common in the post-menopausal age group in females. So the risk factors are most often, it is due to genetic conditions where the cause is unknown and often it runs in families. Apart from that, metabolic syndrome is a very, very important risk factor. Apart from metabolic syndrome, you can also think of excessive alcohol consumption, dehydration, fruits or vegetables or food which is basically high in fructose, excessive consumption of red meat, right? So all of these can precipitate a gouty attack, and all of this is considered to be risk factors on their own, right? So when we speak about precipitating factors, always counsel your gouty arthritis patients about alcohol, dehydration, fructose rich food and red meat consumption. Okay, so that is about your risk factors and precipitating factors. So how is the presentation? The presentation is an acute onset. Okay, this is an acute onset, explosive in nature. It is explosive in nature. Excruciating pain, severe pain. Pain of what? Painful swelling of the joint. Okay, so this is a monoarthritis and it's the most common presentation is a monoarthritis, acute onset, explosive, excruciatingly painful monoarthritis is the description for an acute gouty arthritis. Okay, so what is the most common joint that is involved? It is usually the first metatarsophalangeal joint, sometimes the knee, sometimes the ankle, all of it can be involved. So can you see here that there is a redness and swelling of the first metatarsophalangeal joint. So most of the time these gouty arthritis patients are usually fine when they go to bed and they get up with a swollen toe, right? So there is acute onset explosive painful swelling which is monoarthritis, right? So when we speak of the signs, what all can you find? So what are the signs? The signs are there can be tenderness, it is excruciatingly painful, there is severe tenderness of the joint, then there is swelling of the joint, there is redness over the joint, there is warmth over the joint. Okay, and most often it is a monoarthritis, and in such conditions always remember that septic arthritis is a very, very important differential diagnosis because it is a monoarthritis. Alright, fine. So what are the types? It is classified as an acute gout and a chronic gout. So when we speak of chronic gout, how is it going to present? It is going to present in the form of relapsing remitting course, right? So they have an episode of a monoarthritis and usually it settles down within few days, and then they have recurrent episodes of arthritis again. They have recurrent episodes of arthritis again. So there are recurrent episodes of arthritis, and the time in between the flares, they are usually asymptomatic. Okay, so that should be very, very clear. Between two flares, the patient is usually asymptomatic, right? Now, if this goes on and on, So there is a flare, there is normalcy in between, there is a flare. It can result in the formation of what we call as tophi. Okay, you can have tophi, which are basically soft tissue deposition, and nodules which are present in these joints which are often affected. So can you see here? These are your tophi, and these are nodules of depositions which is present over multiple joints, and this can be even present in the subcutaneous tissue. It can be present at the point where the tendons join, like over your Achilles tendon. It can be present over the pinna of the ear. Okay, so acute gout, you have severe excruciating pain, then in between the flares they can be normal, and over the course of time they can also go on to form something called as a chronic gout. Okay, now how do you describe your acute gout? We have understood your acute gout basically comprises of a excruciatingly painful monoarthritis. Now, how will the pain be? The pain usually starts from 2 to 4 hours and it peaks by 12 hours. It peaks by 12 hours. And how long does it last? It lasts for around 24 to 48 hours. It lasts for around 24 to 48 hours, and then it resolves, right? And then it resolves. So very importantly, even if you don't do anything for an acute gout, it may resolve on its own. Okay? But the characteristic feature is that in between two episodes, there may be normal and then there can be a recurrence again. There can be flare-ups and finally it can result in chronicity. Okay? So this is how your gouty arthritis usually presents. Fine? Clear? Okay. So let us understand how do you diagnose your gouty arthritis. So what we would say, the investigation of choice would be a synovial fluid analysis. Because this is a monoarthritis, you will always have to rule out septic arthritis, and hence you may have to take a joint aspiration, right? So you might ask me, why not serum uric acid levels, right? Because serum uric acid levels have to be elevated in gout. But remember that in gouty arthritis, during a flare, uric acid can be normal. Uric acid can be normal. So serum uric acid levels can be normal during a flare of acute gouty arthritis. Okay, fine. So you have to do a synovial fluid analysis, rule out septic arthritis. Always rule out septic arthritis in a monoarthritis. So what will you see? You will see that the gram stain will be negative. The counts will be in the inflammatory range of around 2000 to 3000. And most importantly, because this is a crystal arthropathy, you will find evidence of crystals. You will find evidence of uric acid crystals. And how do you identify the uric acid crystals? You put them under a polarizing microscope and they undergo birefringence, which is a negative birefringence, needle-shaped crystals. Very important. Can you see this needle-shaped crystals? Right? You put them under a polarizing microscope. So they are negatively birefringent. Okay? So negatively birefringent needle-shaped crystal is a characteristic feature of acute gouty arthritis. Clear? So this is how you diagnose your gout. Now, how do you treat an acute episode? So treatment of the flare, the first line of choice of treatment would be NSAIDs. Okay? So NSAIDs, the drug of choice is indomethacin, and this is given as a 25 mg TID dose, or naproxen, which all of these NSAIDs have anti-inflammatory properties. So these are the drugs that can be used, right? Then colchicine is the second drug that you can give. Colchicine, the advantage is that it should be started within 1 day, otherwise it may or may not work. But it has excellent anti-inflammatory properties and also it helps in reducing the episodes of flare. So 1.2 mg you have to give stat, followed by 0.6 mg after 1 hour, and you continue this dose for around 1 week. You give 0.6 mg in the morning and in the night, and you will have to taper it down over 3 to 6 months, and this ensures that it helps in preventing recurrent flares as well. Okay, fine. The third management in a severely painful arthritis, you can give out intra-articular steroids. Intra-articular injection of steroids can be done, but always rule out septic arthritis before injecting into a joint, and hence this has to be done. Okay, what is the role of uricosuric agents or drugs which are useful in reducing the uric acid levels in the body in acute gout? So in acute gout, if you give them an allopurinol or you give them a febuxostat, which are basically drugs which help in reducing the uric acid levels, it can increase the flare. It can increase the flare, and hence only after the flare settles down, you try and initiate them on urate-lowering therapy. Urate-lowering therapy. So urate-lowering therapy is usually not recommended during an acute gout. Okay, clear? Fine. So this is about your acute gout. So now let us move on to chronic gout. So in your chronic gout, what are the characteristic features? Yes, definitely you will find evidence of tophi. Then there are certain signs that you have to know. So what is the X-ray sign? So in the X-ray, if you do of the hand, you will find erosions in the lateral aspect of your fingers, right? So you may find erosions in the lateral aspect, which is basically punched out lesions. So you will find evidence of punched out lesions with overhanging margins. Right? So punched out lesions with overhanging margins, especially in the radial aspect of the hand, and this is what we call as the Martel sign. This is what we call as the Martel sign, which is an X-ray sign of chronic gout. Then what do you find on the ultrasound? So what do you find on the ultrasound? If you do musculoskeletal ultrasound, you will find evidence of monosodium urate crystal deposition within the cartilage, which is occurring like a hyperechoic region, and it is well distinguished from the underlying normal cartilage, and this is what we call as the double contour sign. Okay, so double contour sign is another sign which you find in your musculoskeletal ultrasound in gout. Then the final investigation of choice would be something called as a DECT, which is a dual energy CT scan. Dual energy CT scan. This dual energy CT helps in identification of tophi deposition. Okay, so these are the various investigations which you can do for the diagnosis of chronic gout. So when it comes to the treatment of chronic gout, yes, here you will have to use urate-lowering therapy. What are the urate-lowering therapies you want to use? You can use allopurinol. You can use allopurinol, which is a xanthine oxidase inhibitor, or you can use Febuxostat. Right? So in chronic gout, you have to use allopurinol or Febuxostat to bring down the uric acid levels. Clear? So this is about gouty arthritis. Let us move on to the next type of crystal arthropathy, which is your CPPD disease, which is your calcium pyrophosphate deposition disease. So this is a disease of elderly, and most often it is an asymptomatic non-inflammatory condition, right? Most often it is an asymptomatic non-inflammatory condition. It's a disease of elderly. So CPPD disease has a varied presentation. Okay. So what are the different clinical presentations of CPPD? First is chondrocalcinosis. So most often when you take the X-ray of an individual with CPPD, you might find a deposition of CPPD within the cartilage, and you might find evidence of chondrocalcinosis, which appears as opaque lines within the cartilage. So that is one of the most common presentations. If CPPD presents as a monoarthritis, so how is it going to present? If it presents as a monoarthritis, is going to be a differential for gouty arthritis. It is going to be a differential for septic arthritis. Okay. So if CPPD presents as a monoarthritis, it's going to be a differential for gouty or septic arthritis. So you will have to do a joint aspirate, and if you do an aspirate, you will find evidence of a bloody aspirate. Okay. And if you send it for analysis, what kind of crystals will you get? So this is the most important distinguishing features. You get rhomboid shaped crystals. You get rhomboid shaped crystals with a positive birefringence. You get rhomboid shaped crystals with positive birefringence. Okay, so this is exactly the image that is showing here, rhomboid shaped crystals which are showing a positive birefringence under the polarized microscopy. That is your CPPD disease, right? And this is how you differentiate it from gouty arthritis. Okay, so this CPPD can be asymptomatic, it can be in the form of chondrocalcinosis, it can be in the form of monoarthritis. Also, CPPD is considered to be a great mimicker, and hence it can present in the form of a pseudo-RA or a pseudo-OA pattern. Pseudo-rheumatoid arthritis pattern basically means that it is going to present as a symmetric, erosive, bilaterally symmetric, erosive arthritis, very similar to rheumatoid arthritis, but here RF and anti-CCP will be negative, and RF and anti-CCP will be negative. Also, it can mimic a pseudo-osteoarthritis pattern, right? Then it can also involve the metacarpophalangeal joint, and if this involves the atlantoaxial joint, if the CPPD disease involves the atlantoaxial joint, then this is what we call as the crowded dense syndrome. Crowded dense syndrome. Okay, fine. So this is about the various ways in which the CPPD related disease can present: chondrocalcinosis, monoarthritis, pseudorheumatoid, pseudo-osteoarthritis, and crowded dense syndrome. So what are the associations of CPPD related disease? CPPD related disease may be asymptomatic, but we have to know the associations. It's associated with hyperparathyroidism, hypophosphatasia, hypomagnesemia, hemochromatosis, right? In the hemochromatosis, like if it is associated with that, you may find evidence of hook-like osteophytes. You may find evidence of hook-like osteophytes, right? So how do you manage your CPPD related disease? Management basically involves long-term colchicine therapy. It involves long-term colchicine therapy, right? Fine. So with this, we have come to the end of our discussion on crystal arthropathies. Thank you.